Presenting a new series, Medically Verbal, where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attempt these processes without the guidance of a licensed medical professional. Case 11. Chief complaint. A 30-year-old male presents to the emergency department with acute onset, severe right lower quadrant abdominal pain. History of present illness. The patient describes sudden onset of pain that started in the periumbilical region, which is the area which surrounds the belly button, and migrated to the right lower quadrant over the past 12 hours. He also reports nausea and had vomited once, which did not contain any blood. He denies fever, diarrhea or dysuria, difficulty in urination. Does not have any past medical history. He is not a smoker, occasionally uses alcohol, works as an accountant. Family does not have a history of gastrointestinal disorders. His BP is 120 systolic, 70 diastolic, heart rate is 80, respiratory rate is 16, temperature 37. His abdomen is distended, there is tenderness present which is in the right lower quadrant. There is rebounding tenderness present but the bowel sounds are diminished. Initial differential diagnosis: appendicitis, right-sided diverticulitis, Meckel's diverticulitis, acute mesenteric ischemia, ovarian torsion. Based on this presentation, what do you think is the most likely diagnosis and what further investigations or management steps would you recommend? Let's see the diagnosis one by one. Appendicitis, what is it? It's basically inflammation of the appendix. Right-sided diverticulitis, it is basically the pain in right lower quadrant which is matching with the symptoms, but it also presents with fever and the patient's temperature is normal. Meckel's diverticulitis, it could be a condition but it is something which is diagnosed in birth and the patient does not have significant past medical history. Basically, the vitelline duct fails to vanish during the 5th intrauterine week. Then there is acute mesenteric ischemia. So basically the blood flow to intestine, small or large, is diminished or blocked due to any obstruction present. And ovarian torsion may not be a case here. It might be a case if a similar case study is present in case of a female. If you're thinking appendicitis or Meckel's diverticulitis, you might be right. How we're going to check it out? We'll perform a CBC to check for leukocytosis. Because there is inflammation, there is a high chance that the WBCs would be on a hike. We'll check the CRP level, again inflammation, and this would help us to know the severity of appendicitis. Now we'll do pelvic ultrasound. In both genders, it would help us to know the location of appendix and the structures that are guarding near to it. CT scan of the abdomen and pelvis should be done if the above imaging techniques remain inconclusive, okay, and we still feel that there are complications. So how are we going to manage it out? For appendicitis, we would provide them with a surgical consultation because that is the treatment. We'd initiate them on intravenous fluids and antibiotics like metronidazole. Then for Meckel's diverticulitis, we would again suggest them surgical consultation or diverticulectomy or management based on severity and complications. Okay. Hope you like the case study of today. You can come back whenever you want to sum it up. Please make sure that this is not a substitute of medical advice and is just for understanding purposes of how to diagnose and solve case histories. Corrections or suggestions, comment down below. Make sure to like, share, subscribe and hit the bell icon to never miss another update.